welcome to you all. I'm Amit Khera. I'm Vice Chair of the American Heart Association Committee on Scientific Session Planning. We're so excited to have you. This is one of our first ever case conference competition. We were trying to align it a little bit with the Olympics, gold, silver, bronze. You are our 6 gold medal winners. That means you have outstanding cases, very interesting and well presented in your write-ups. I want to acknowledge from the American Heart Association perspective that, there's so much science that we present at the upcoming sessions, and science and clinical medicine go hand in hand. So we're going to hear about some scientific advances, but also what you all have reminded us and show us, and something that we think about all the time is, clinical medicine and decision-making and thought process and all the different sort of treatment options and algorithms and the art of medicine. And that you're definitely presenting in addition to the science of medicine as well. Thank you for that and reminding us of our charge and mission. And what we'll do today is go one by one through each of you, hear a little bit about yourself, have you present the case and maybe some brief discussion on that, and then we'll work through today. And we'll record this, of course, as we're doing so that all can see about these cases and celebrate your interesting cases and your award-winning cases here. So without further ado, I'm going to begin with Dr. Ling. Please introduce yourself and tell us about your case.
All right. This is Dr. Ling from Taipei Veterans Children's Hospital, Taiwan. And my subspecialty focus on the electrophysiology and also the cardiovascular imaging. And this is a case with cardiac sarcoidosis mimicking ARVC presenting with syncope. And I submit the cardiovascular imaging for the case competition. This is a 35-year-old man who suffered from dyspnea on exertion for half year. And this time he had the palpitation with chest tightness with nearly syncope. He called 911 and was brought to the local hospital for help. In the emergency department, the electrocardiogram showed sinus lesion with first-degree AV block, PR interval up to 360 milliseconds, RBBB pattern, and the PVC with left bundle, left superior axis, V4, V5 precordial transition, which favor RV origin. In local hospital, the computer tomography and the echocardiography were performed, and we can see the dilated RV and also dilated RV and also the multiple lung nodules over the bilateral lung, especially upper lung fields. The patient was suggest the local cardiologist think it's ARVC, so suggest him to receive the ICD implantation and maybe catheter ablation. Patient hesitated and visited our hospital for help. According to the 2010 ARVC task force criteria, he only meet the 1 major criteria with RV dilatation and focal dyskinesia. Also the VPC, the Holter burden, 24 hours Holter burden is 1%, around 900 beats per day. So he visited our hospital for help, and I arranged the cardiac MR imaging for further evaluation. And we can see in the cine image, there's a dilated RV and the focal dyskinesia over mid to apical RV free wall. The delay enhancement image shows the RV delay enhancement over RV, also the interventricular septum and free wall. And the interventricular septal delay enhancement protrude extend to the interatrial septum. So, and this is quite scary, this pattern. The patient have the previous report that it raised the suspicion of cardiac sarcoidosis due to this epicardial multifocal delay enhancement, also the RV free wall is hook sign. So I arranged the myocardial PET imaging, and we can see the multiple FDG uptake over the heart, lung nodule, and supraventricular lymph node. So I did the endomyocardial biopsy. However, it only showed the myofibrosis. So I consult the surgeon for help. He did the wake resection of the lung nodule, target this peripheral lung nodule, and which showed pathology showed the granuloma, and this granuloma along with the bronchoalveolar bundle. So it's proof of the lung sarcoidosis. So according to the 2017 new cardiac sarcoidosis guideline published in Japan, our patient meet 2 major criteria, including the FDG uptake, delay enhancement on cardiac MR, and also abnormal electrocardiogram finding with the bundle branch block and ventricular arrhythmias. So two major criteria on imaging, one minor criteria on ECG, and the biopsy proved the intracardiac sarcoidosis. So we confirmed the cardiac sarcoidosis. I give the patient a prednisolone 30 milligram a day. After 1 month treatment, we can see the ECG have the gradually improvement. The PR interval shortened from 360 milliseconds down to 220 milliseconds. But there's still the PVC original from RV. I think it's quite makes sense because the FDG uptake only at the left ventricle, but not right ventricle. So the disease conduction system have mild improving, but not the PVC. So here is my case summary and the key lessons. I think the important thing is when we have the suspicion of RV cardiomyopathy and ARVC, I think we always need to think about the cardiac sarcoidosis that with RV involvement, and especially with the disease conduction system, it's very not usual in the ARVC patients. And application of multimodality imaging is the key role for the accurate diagnosis. If we have these tools, powerful tools, we should do that. Thank you for your attention. I would like to thank my wonderful colleagues, my mentor, Professor Xian Chen. Thank you for your attention.
Thank you for a great case, really a great presentation with multimodality imaging and the electrophysiology component. So there were so many different pieces there. You know, you pointed this out. The one part to me is the initial thought of ARVC. You know, heart block is not a usual presentation. So what do you think led them to head down that road and seeing a young person with heart block where that became what they were thinking?
If the patient present with heart block and young age without any other cause, I always be very, very careful and do more survey for the patient instead of the direct pacemaker implantation. I think the challenging thing is some young patient visit our hospital with complete AV block directly. We just need to let them admit to CCU, and I think it's hard to arrange the cardiac MR or advanced imaging before we put the pacemaker because it takes time. I mean, we always need other department to help us to arrange this advanced imaging study. I think in the past 20 years, it's hard. So we usually just put the implant the pacemaker and may search the possible cause in the future. But usually we don't have the answer. So I think with patient and us, we are quite lucky that we make the accurate diagnosis before he suffer from more devastating event like sudden death. Because when I see this delay enhancement, I just call the patient directly, call him back in the next for the next outpatient clinic. Just 1 week.
Tell me about his subsequent care. As you pointed out, you started him on steroids, and his PR interval maybe had shrunk a little bit, but he's still having arrhythmias. He still has cardiac involvement of a sarcoid. How do you counsel him in terms of whether there's a necessity for any device-based therapy, pacemaker, ICD, and what do you anticipate for his course?
Yeah, I think it's quite challenging. I searched several literature. Since the patient with cardiac sarcoidosis, they frequently diagnosed in a different stage. So for my safety, for patient safety and our team safety, I of course suggest him. I always inform them the risk that he may have sudden cardiac death because of this extremely long PR interval. Maybe one day he just has the complete AV block and just have sudden death. I also offer him the choice. He may need the pacemaker for prevention of sudden cardiac death because of AV block. But you know, patient is 35-year-old and he never heard about this disease, and I think he searched several news and the articles that they don't know what this cardiac sarcoidosis means, and they don't know what the risk of it, even though I explained to him. So even though I provide the choice of pacemaker, he refused it. And I think ICD is not needed now, since the PVC burden, and I also provide him the frequent monitoring. Every 1 month, I provide 7 days monitoring, and the PVC just show around VT just 3 beats, and it can suppress by methylating. So I think ICD is not indicated now, but the pacemaker, I did provide him this choice, but he refused. So I think we just have, cross monitor.
Thank you for a great case. Certainly appreciate it's challenging, particularly in a young person, and no one has ever heard of sarcoid until they actually have sarcoid. So I definitely understand that. Thank you, Dr. Ling. We'll move on to our next presenter, Dr. Yaz. Why don't you tell us, you can start sharing and tell us a bit about yourself and then your case.
Okay, hello everyone. My name is Mustafa Alam. I'm currently a third-year medical student at the New York Institute of Technology, College of Osteopathic Medicine, and I'm here to present very briefly a very interesting case of recurrent atrial myxomas as a presenting feature of a Carney complex. So as a case presentation, this was a 24-year-old man who presented to the hospital after losing consciousness in the swimming pool, and he was found to have an acute middle cerebral artery stroke. And his past medical history was actually very interesting. It was significant for adrenal insufficiency, a previous left atrial myxoma that was removed, status post-resection, and known left frontal brain masses, left adrenal and testicular masses that were previously also removed, status post-resection. In terms of the family history, the father had a history of also a resected left atrial mass. And on echocardiography, he was found to have a left atrial mass measuring 4.8 centimeters in size attached to the septum with a stalk. And this was assumed responsible for the said stroke. And interestingly enough, while we were doing a physical exam, the rest of the physical exam was otherwise normal, but in particular, skin was noted to have multiple hyperpigmented macules resembling cafe au lait spots. So really in this, taking this history, some things that come into mind are, diagnoses such as neurofibromatosis, maybe multiple endocrine neoplasia. And well, this led us to do a CT. And on CT, this revealed a recurrent adrenal neoplasm on the left adrenal, which was previously resected, and now we realized that it came back. And looking at this constellation of signs and symptoms, this was ultimately diagnosed as a case of Carney complex. With all the, specifically the history of the adrenal insufficiency, the adrenal and testicular masses, this very unique presentation is very typical of Carney complex, and in particular is the recurrence of this myxoma. So really the key takeaways I want to focus on is that Carney complex can include myxomas that can recur, cafe au lait spots, and recurrent endocrine tumors. It can also present with adrenal insufficiency, and in this case, in about 3 years, the left atrial myxoma actually returned. Right, so screening is important to prevent major strokes in these patients once this unique presentation has been identified. And here I have an image of the echo. All right, and thank you so much for your time.
Thanks for an excellent case. Hey, listen, I want to first congratulate you. It's very rare we have a medical student presenting in a conference like this. So congratulations to you for submitting such an excellent case and for working through with this patient. So wonderful for you. Maybe I'll ask you a little bit about I've always found this complex fascinating, particularly the physical exam with the periorbital. You can get these sort of spots and things that are you always see in textbooks. The thing that's interesting is this patient had a previous myxoma, but it sounds like were they not being followed with echoes or surveillance for recurrence? Because of course these can be recurrent. Was the patient lost to follow-up, or how did this come back without anybody detecting it?
Yeah, unfortunately, it was lost to follow-up. He presented to the emergency room with this new onset, stroke-like symptoms, and then, on the echo, wow, we found this mass. So then, obviously, this patient was counseled on, especially at being at high risk for the recurrence, within just 3 years, and it's in a positive family history as well. So at this point, based on each clinician has a different, risk assessment. So maybe it would be good to, assess maybe at least once a year for this patient to see if, there's recurrence of that myxoma, and there's a high risk for embolization as well. So it's good to follow up with this patient.
Yep. And obviously I know this patient had some challenges with the stroke, but I guess the next part to this is once you identify it, tell me a bit about family screening. Had that been discussed at all? I guess obviously the focus was on the patient and the challenges of his stroke, but a little bit about family screening and how we think about that once you identify a patient with Carney's.
Mm-hmm. Yeah, definitely. There's a gene that's related to the Carney complex, autosomal dominant. So it's definitely very important to screen family members, especially at least if they have this myxoma, right? And so especially with the family penetrance, is definitely important to evaluate the family members as well.
Well, listen, thanks again for presenting an outstanding case. Congratulations to you in general as one of our gold prize winners, but equally as much as a medical student. We hope to see you many years coming back to the AHA sessions. Well, we're moving along to our next gold prize winner finalist, and that's Dr. Vinakota, looks like from Mayo Clinic. Why don't you introduce yourself, tell us about your case.
Hi, Dr. Khera. Hi, everyone. I'm Shravya. I'm one of the third-year cardiology fellows at Mayo. I will be doing an advanced fellowship in multimodality imaging, and that's the third year integrated into the imaging track. So I'm technically a cardiac imaging fellow at this point. And I'd like to thank you all for the opportunity of presenting my case. Just give me a moment here to start sharing my screen. Well, thank you, AHA and the panelists for this opportunity. We wanted to present a case of radiation-induced accelerated multi-valve disease in a patient who we saw here in the valve clinic with prior history of a subaortic membrane. So this is a 69-year-old woman presenting with progressive symptoms of NYHA class 3 dyspnea, not being able to walk, feeling tired. And I'm going to skip through the slides with the text here so we can get to the real nice images in the interest of time. Her past medical history was notable for breast cancer 18 months prior to her presentation to us. And she had a history of lumpectomy and radiation of about 4.2 centigrade. I know as cardiologists for that, it's not, for us, it's hard to put that in context, but we'll go over what 4.2 centigrade of radiation would mean for us. Her transthoracic echo prior to her cancer diagnosis was relatively unremarkable, besides the finding of a subaortic membrane, which is a congenital abnormality, somewhat rare, but not unfrequently encountered in our practice, with a mean Doppler gradient of about 21 millimeters of mercury. The rest of her valves look pretty good. Her mitral valve was maybe a little thickened, but nothing too abnormal there. And her physical exam showed findings of several different murmurs. She had a holosystolic murmur, she had a separate ejection murmur, and she also had an early diastolic murmur. So it's very different from what her transthoracic echo from earlier would suggest. So here are her echo images from her transthoracic echo that we got initially when she presented to us. So we can see in the parasternal long axis view here, very thickened ventricular walls, biventricularly thickened, the right ventricular free wall here, as well as both the ventricular walls. Her mitral valve was really thickened. You can see a hint of that subaortic membrane that was referred to in the past, a little ridge that's projecting into the left ventricular outflow tract. And then in the parasternal short axis view here, you can see increased left ventricular wall thickness, as well as the thickened mitral valve and short axis. A couple more views here from the apical side here, again demonstrating just how strikingly thickened her mitral valve is, how thickened both her ventricular chambers are. You're seeing some evidence of atrial enlargement too, so suggesting that her filling pressures are now elevated. And then here you can kind of see how narrowed out that LVOT is with the subaortic membrane and the aortic valve over there. And then some 3D views in short axis. And then color flow across these valves, again demonstrating mixed valve disease. So explains some of the murmurs that we were hearing on her physical exam. She has evidence of severe mitral regurgitation, this big blue jet going from the left ventricle into the left atrium. She also has evidence of left ventricular outflow tract obstruction in the setting of that aortic subaortic membrane, as well as that big red flow going back from the aorta into the left ventricle, suggesting moderate aortic regurgitation. She also had some element of mitral stenosis. This is a Doppler gradient across that mitral valve and diastole, showing a gradient of 8 at a heart rate of about 63. And typically anything over 5 to 6 is generally considered fairly severe. So mixed mitral and aortic valve disease. So these are the transthoracic echo features we discussed. Some cardiac CT images here, which kind of again demonstrated the same findings that we were just talking about: biventricular hypertrophy, subaortic membrane, the LVOT narrowing, and then again that thickened mitral valve here, that anterior mitral leaflet that is just significantly thickened, for example, in comparison to this posterior mitral valve, which is also relatively thickened, but not quite as striking as that anterior leaflet. So she went in for surgical management for her valve disease, and the images here are also quite depictive of how severely fibrous these mitral valves and the subaortic membrane were when we looked at the gross pathology specimens. And then her surgical pathology here showed evidence of myocyte hypertrophy, interstitial fibrosis. Her valve also showed evidence of some post-inflammatory changes. I put this comment in here from one of our pathologists because he commented about how peculiar these findings were, because there was primarily fibrotic valve thickening, but they also saw that the vessel walls within the valves itself were thickened, which typically is seen as a post-inflammatory change. And given this prior history of radiation therapy, that was the only possible explanation we could find to explain these findings. In addition to that, we also talked about her myocardium being thickened, and they mentioned that the myocardium itself was hypertrophied and fibrosed. She did really well after surgery. These are her CT images post-operatively. She had some minor complications from open heart surgery, of course, but overall did really well. Her CT scan looked incredible. No evidence of outflow tract obstruction before she was discharged. She participated in cardiac rehab and did really well. So for radiation-induced valve disease, it's not something we know a lot about because as cardio-oncology is still a relatively developing field, but typically we see a latency period of almost 10 to 20 years for these patients. They get radiation. We hear about these patients who've had mantle radiation in the 80s or 90s, and now in the 2000s, 2010, they're coming in with evidence of radiation-induced heart disease. And then these are the doses that we could find in the literature for evidence to suggest that they could have bad effects on the heart from the radiation: 25 gray, 30 gray, or 33 gray. So those are the doses that we were typically looking at. But if you recall, our patient had 4.2 centigrade. So that is quite a remarkable pathology to develop, considering how her disease wasn't as bad to begin with. It can be hard to diagnose radiation-induced valve disease. The findings are relatively non-specific, but this area of aortomitral continuity, this aortic valves, the mitral valves anterior leaflet continuing into the aortic valve, often gets involved more significantly than the rest of the heart, and that can be somewhat specific to identify radiation-induced valve disease. So the issue with this is we don't really have any data about patients who have pre-existing valve disease. We know how to classify these patients in terms of their risk when they're exposed to radiation, but we don't really have any guidelines about people who do have pre-existing valve disease. And that could be on a spectrum of just mild disease, like our patient with a mildly thickened mitral valve. She did have a subaortic membrane, but the gradient across that wasn't particularly high. And what do we do in these patients? Should we recommend that they don't get radiation? Or should we recommend that if they do get radiation, we ensure that they're followed more closely so we can identify this development of valve disease before they get much worse? And we really have no data about this. So to summarize, our point was that potential candidates for radiation therapy must be carefully screened for pre-existing valve disease. And we should be more vigilant and be screening these patients for progressive disease if they do have any evidence of pre-existing disease, and to consider newer techniques to modulate dose and intensity of that radiation therapy. So that brings me to the end of my presentation. Thank you for your time and attention.
Wonderful presentation, really a fascinating case, and appreciate the imaging and the pathology that you showed that really rounds out the case well. You know, the fascinating parts are just the rapidity with which this occurred. I'm reading your case report. If I got this right, this was right-sided breast cancer. Did I get that right? Or
It was,
that,
yes.
that adds to the unusual nature, because usually, even in sort of historical articles about risk with breast cancer related radiation, it's usually left-sided for obvious reasons of heart anatomy. How did that happen if it's right-sided breast cancer?
Absolutely. That is a very good question. And that's the question we had too. I used my word limit in my abstract very carefully, and I put the word right in because I figured that's unusual. We usually see this type of presentation in patients, of course, after a long latency period of 10 to 20 years, but more in the patients who have history of lymphomas with whole mantle, whole chest radiation. But for something like this to develop for localized right-sided radiation is just very unusual. It makes you question if there was something that went wrong with how the radiation was being administered and she accidentally got a higher dose than was expected, or if it wasn't targeted appropriately, or if we just don't know enough about the pathophysiology of this, and if there's some underlying predisposition for some patients to develop this more so than others would.
Yeah, and I might extend that because the valve part is obviously fascinating, but the thickening of the myocardium, the infiltration, and I'm glad you had histology, because it was going, through my head at least, is this amyloid, is some other infiltrative cardiomyopathy. But
exactly,
I wonder, again, that's a little bit unusual to have that degree of fibrosis and hypertrophy so rapidly, and I wonder in terms of how she will do, despite her valves being, she might have some restrictive physiology.
Yeah. Because she did have the subaortic membrane that can potentially cause some secondary remodeling, but her gradient was only 36. So the degree of obstruction and the duration for which her ventricle was exposed to that obstruction, neither of these features were significant enough to explain that degree of ventricular hypertrophy, almost like you mentioned, like an infiltrative cardiomyopathy or a hypertrophic cardiomyopathy, but all of the pathology was non-specific with possible radiation-induced changes being suggested, which is fascinating.
Okay, well, we're going to keep scratching our heads, and maybe we'll have you come back in a year or two to tell us a follow-up on this case. But thank you very much. We appreciate it. We'll keep moving forward. Next, we have Dr. Benjanu Watra, who's going to tell us about himself and about the case.
Greeting everyone, my name is Tudipong Benjanwatra. I am currently a PGY1 in internal medicine intern at Texas Tech University Health Science Center in Lubbock. So today I would like to present my case of unexplained recurrent ST elevation myocardial infarction complicated by diffuse alveolar hemorrhage in undiagnosed granulomatosis with polyangiitis. And I submitted this case for a general cardiology case. This is a 53-year-old male patient. He has a past medical history of hypertension and dyslipidemia that are well controlled. And he presented with substernal exertional chest pain. He went to the outside facility and he was diagnosed with anterior wall ST elevation myocardial infarction 3 weeks prior to our hospitalization. At that time, PCI was performed and proximal stent was placed at proximal LAD. And at that time, he was discharged with aspirin and clopidogrel. However, 2 weeks later, he presented again with recurrent substernal chest pain, and EKG showed anterior wall ST elevation myocardial infarction again. So they performed the left heart cath, and coronary angiography showed instant thrombosis with new thrombotic occlusion extending throughout the LAD. So after the second time of ST elevation myocardial infarction, he was discharged home with aspirin, clopidogrel, and rivaroxaban. And however, a few days later, he started to develop mild hemoptysis. So he came to our hospital and we stopped the aspirin. But shortly after, he had worsening hemoptysis and he had massive hemoptysis with acute hypoxemic respiratory failure. So he was admitted to our medical ICU and he was there for about a month. And this is the images that we got. So by the time he came to our hospital, his chest x-ray showed diffuse bilateral alveolar opacities, and we did the CAT scan of the chest. It showed diffused ground glass appearance consistent with massive pulmonary diffuse alveolar hemorrhage. So I'm sorry, I didn't include the laboratory investigations here, but laboratory investigations showed positive for anti-PR3 cytoplasmic anchor antibody, and his complement level is elevated. And he had acute kidney injury as well, and there is a hematuria in his urinalysis examination. His ESR, CRP are all elevated. So we diagnosed him with diffuse alveolar hemorrhage and granulomatosis with polyangiitis. So rheumatologist was consulted, and he was started on induction therapy with methylprednisolone, cyclophosphamide, and his clinical condition gradually improved, and he was successfully extubated after a week, and he stayed in our hospital for about a month, and he was discharged home on clopidogrel and immunosuppressive regimens consisting of prednisone and mycophenolate mofetil. And this is a learning point for this case. So the high index of suspicion is very important for the possibility of non-atherosclerotic coronary artery stenosis, such as in coronary vasculitis, and careful monitoring for bleeding complications in acute coronary syndrome is very important, especially in patients receiving antithrombotic medications. And in patients with recurrent ST elevation myocardial infarction, one of the possibility is vasculitis, and it should be suspected in this kind of patient. And I have a follow-up for this patient. So a few weeks later, after we discharged him with clopidogrel and immunosuppressive regimens, I just learned that he came back again about 3 weeks after that with a third ST elevation myocardial infarction. And we did the PCI again, and it showed instant thrombosis again. So we did a revascularization. However, his course of hospitalization was complicated by salmonella septicemia. So unfortunately, the family decided to pursue comfort care for him. So he passed away shortly after that. So another learning point for this case is that it is a very tough clinical decision to make in this case, because at first he was prescribed aspirin and clopidogrel like general STEMI management, and that was not enough. And he had a recurrent ST elevation MI. So after the second time, he was discharged home with triple therapy, aspirin, clopidogrel, and rivaroxaban, and that caused him bleeding complications with diffuse pulmonary hemorrhage. So by the time that he was hospitalized at our hospital, we kind of weighed the risk and benefit of prescribing these medications, and we decided to prescribe him with only clopidogrel in combination with immunosuppressive regimens, because there is no specific guideline to determine which medication to be used in this kind of situation. So it's a very tough judgment call, and unfortunately, he came back again with third ST elevation myocardial infarction. So the possibility is that clopidogrel and immunosuppressive regimens are not enough, or it could be that he has like a cytochrome P2C19 genetic polymorphism that caused him resistant to clopidogrel. We do not know that, or he could have underlying hypercoagulable disease, and in that case, hematology was also consulted during the second time he was hospitalized in our hospital. But at that time, he has active thrombosis. So the hematologist thought that the test will not be accurate at the time of acute thrombosis, so they didn't do anything. So they planned to further work up after that, but unfortunately, he passed away before that.
Thank you for the case. Obviously, a challenging one clinically with the patient's outcome, but great case again. Also glad to hear of a PGY1 resident presenting today, not just cardiology fellows, so the full spectrum. So appreciate your presentation of that case. My question to you is your first teaching point about suspicion for non-atherosclerotic or primary atherosclerotic or contributing factors of vasculitis. Was there anything on the angiogram, first, second, or third? I did see that CT. I could see the stents in the LAD, but
yes.
anything on the angiogram suggesting vasculitis by its appearance?
So the first and second angiogram was I'm sorry, the first and second angiogram was performed from outside facility. So we only have the record of their PCI. They didn't do the biopsy, so we cannot be so sure about the coronary vasculitis, but they did mention that there is like a 100% occlusion from thrombotic occlusion in the LAD from the first time, and for the second time, there was an instant thrombosis with new thrombotic occlusion, proximal and distal to the stent that they placed. But we don't have any biopsy report.
Or yeah, 'cause sometimes you might see, small aneurysms or beading or something that may suggest vasculitis.
They didn't mention beading or aneurysm.
I see. And then, the challenge in this case was obviously recurrent in-stent thrombosis. And as you pointed out, with the anticoagulation that exacerbated the alveolar hemorrhage, I'm curious about, I'm not familiar with this, about the association of these vasculitides with increased risk of thrombosis per se. As you pointed out, it could just be he had Plavix resistance due to mutations, and there's obviously a lot of different anticoagulation strategies. Or anything about vasculitis and hypercoagulability as relates to stent thrombosis that you came across?
Yeah. So in general, in patients with with systemic vasculitis, one of the possibilities causing acute coronary syndrome is, of course, coronary vasculitis. The second possibility is that in case of systemic inflammation, there is an accelerated atherosclerosis process. So patients may have a very bad atherosclerotic plaque despite having well-controlled other cardiovascular risk factors such as hypertension, diabetes, dyslipidemia. So by having the systemic vasculitis itself, he may have atherosclerosis in the coronary from the systemic prolonged systemic inflammation.
Okay, thank you. Obviously a great case, and thank you again, and congratulations again on your presentation.
Thank you so much, sir.
Next, we're going to switch screens here and let Dr. Skenga present, introduce herself and present her case.
Hi everyone, my name is Skenga. Thank you so much for having me today. I'm a pediatric cardiology fellow doing a 4th year at Lucile Packard Children's Hospital at Stanford in cardiac imaging, primarily fetal echo. But this is a case from my last year as a general peds cardiology fellow, focusing on complications of a severe case of multisystem inflammatory syndrome in children in our pediatric ICU that we were consulted on. So this case, we had a 10-year-old male who had a known prior COVID-19 exposure, who presented with 7 days of fever, rash, cough, vomiting, and hypotension. He had lab evaluation notable for positive SARS-CoV-2 antibodies, I should say negative COVID PCR, elevated cardiac enzymes, EMP, and inflammatory markers. His initial echo showed normal cardiac function and just a small LAD coronary aneurysm. He was diagnosed with multisystemic inflammatory syndrome in children, MISC, and given methylprednisolone and IVIG per our guidelines. Within 24 hours, just 24 hours, he developed severe LV dysfunction, progressive cardiorespiratory failure, required VA ECMO cannulation, and was started on anticoagulation with bivalirudin at that time. Additional imaging around the time of his onset of LV dysfunction revealed portal vein thrombosis. When he was on ECMO, he required LA vent, so was taken down to the cath lab. At the same time, they did a cardiac biopsy demonstrating lymphocytic infiltration consistent with the myocarditis tape picture. While he was on VA ECMO, he had transient periods of complete heart block and periods of asystole up to 2 minutes, although was fully supported on ECMO at the time. He was on continued immunomodulator treatment with anakinra and infliximab, and then actually had 5 days of plasmapheresis for antibody removal. And with those continued treatments, his inflammatory symptoms and cardiac function and lab markers all improved. He was able to wean off VA ECMO, and at that time, anticoagulation was transitioned to enoxaparin. 5 days later, after coming off ECMO, after he had been extubated, he had left-sided weakness, and so got a brain MRI that revealed an MCA infarct. He was also febrile in this period, found to have MSSA bacteremia. 10 days after coming off ECMO, he had focal right-sided weakness, and a repeat MRI now showed multiple hemorrhagic cortical lesions, which were thought to be thromboembolic with hemorrhagic conversion. secondary to what we presumed was an exaggerated inflammatory response in the setting of this MSSA bacteremia and MISC. Enoxaparin was discontinued at that time. And then after a long, slow recovery, slow anakinra and steroid wean, he was discharged to rehab with normal coronary arteries, normal cardiac function, and normal EKG at that time, but required a long period of neurorehabilitation and is now followed by pediatric cardiology as an outpatient. So just a couple of learning points that I want to talk about. So I think it highlights three important MISC in complications: cardiac dysfunction, a prothrombotic state, and cardiac rhythm abnormalities, which in this case, I think all three contributed either directly or indirectly to his stroke and ongoing morbidity. So we know that cardiac involvement and dysfunction is quite common in MISC. Some reports cite up to 80% of patients presenting with shock or myocardial dysfunction, so not uncommon to see. And then from a prothrombotic standpoint, it's important to recognize that children with MISC can be prothrombotic. There's a recent study from Whitworth et al. Showing that rates of thrombus in patients with MISC or COVID who are 12 or older was 19%, which in a general population of hospitalized children is closer to 1%, so much higher than we're used to seeing in the pediatric world. Risk factors in that population for having thrombus were if you had cancer at the same time, if you had a central venous catheter, if you're older than 12, or if you had out of COVID or MISC, if you had MISC. And then mortality, if you had COVID, MISC, and had a thrombus, in that study was 28%, so quite high. And so basically care teams should remain really vigilant in assessing for complications like stroke and thrombus, and multidisciplinary management is important when you're talking about anticoagulation in these cases, especially patients who might need to be on ECMO. And then talking about conduction abnormalities, this patient obviously had a really dramatic presentation with high-grade heart block, and then this two-minute period of asystole. This is straight from his telemetry monitor, this picture. Looking through the literature, there have been reports of arrhythmia that are quite variable, ranging from first-degree heart block to complete heart block. Other papers have reported ST segment changes, repolarization abnormalities, and then other arrhythmias like NSVT, EAT, atrial fibrillation. We're not used to seeing AFib in our kids. And so in summary, big range of cardiac rhythm abnormalities that you can see in these patients, including high-grade AV block. The underlying cause is at this point unknown, but most likely due to a diffuse myocardial inflammation is the current thinking, similar to our other myocarditis patients. And so routine EKG and telemetry monitoring, even for patients who aren't in a cardiac unit, is important for patients with MISC. Thanks so much. Happy to take any questions.
Wow, fascinating case. Thank you so much for that. And obviously very timely since COVID is the reason that we have a virtual meeting currently, but what an amazing case, and really all of the technology. I'm sure there were numerous folks involved, which helped support this child get through this catastrophic illness. The question for you is, certainly we're seeing MIC, you're seeing it a bunch more, and I also am glad we have a pediatric cardiologist with us today. The question I have is, many patients with MIC, they obviously get ill, but this is, I would call it catastrophically ill. Do we know the risk factors for why some may get quite this ill and others, you put them on IVIG and immunosuppressants and they sort of turn around? What is it that these patients that they really have this catastrophic presentation with severe LV dysfunction? Is there any risk factors or anything emerging? What might relate to that?
Not that I'm aware of thus far. I mean, all of this is still quite new, so I think time will tell. I know there's a lot of work in the immunology world, a lot of ongoing studies, people looking at biomarkers and things like that, but I don't think it's so, not to my knowledge, hammered out yet. But again, like I said, I know that LV dysfunction is quite common in these patients, with up to 80% being affected. A lot of people talk about similarities between MISC and Kawasaki disease. And if you compare the two, with Kawasaki disease, much more likely to see a younger population with coronary artery involvement. And as a contrast with MISC, we're seeing it more in school age and teenage children who are getting quite sick and more likely to have LV function changes. The good news is that in the vast majority of these cases, even this really severe case with appropriate immunomodulatory treatment, function does recover for patients who can get through the initial illness.
Well, that brought to my next question, in terms of, again, this is so new, so we're all learning as we go, of course, with COVID. But in terms of follow up, and I can't stop staring at that 2 minutes of asystole. You can't get your eyes off that.
Yeah.
In terms of long term, one analogy is when people, this isn't the exact same, but we see this with checkpoint inhibitors, and they get myocarditis, sort of an autoimmune inflammatory process, and when they get heart block, there can be problems down the road and necessity for pacemaker. Do we know anything about whether he's out of the woods from an electrical standpoint, or what monitoring?
Our electrophysiology team thinks that now that the period of inflammation has resolved, he should be out of the woods. He's had multiple Zio patches that have all been normal to this point. But believe it or not, he's being followed just yearly now by his pediatric cardiologist. Wow. Yeah, the hope is that this was a one-time event. I don't think there's a true consensus about who's going to get things like cardiac MRI going forward. Some institutions are doing that as part of their policy following these patients long-term. And I would imagine if you had some degree of scar, that might put you at increased risk for ongoing arrhythmia, things like that. But I think most places are still just trying to figure out what kind of follow-up would be most appropriate for their patient.
Thank you for a great case. I guess all's well that ends well. Thanks for your presentation. Finally, we have Dr. Yaz from around the world. Welcome, and please tell us about yourself and about your case.
Yeah, well, good afternoon, everyone. I'm Dr. Yazan Al-Jabri, a cardiac surgeon from Cleveland Clinic in Abu Dhabi. I'm honored here to present my case, the Golden Award case for valvular heart disease, titled Multidisciplinary Team Management of a Severely Ill Pregnant COVID-19 Patient with a Newly Diagnosed Severe Mitral Stenosis. In this case, I'm presenting a 30-year-old, 26-week pregnant female patient with a past history significant only for asthma. The patient presented to the emergency department in an outside facility with shortness of breath, and due to her past history, she was labeled as an asthma exacerbation and with no further investigations discharged with nebulizers. However, 4 days later, on day 5, the patient presents back to the emergency department with worsening shortness of breath, high-grade fever, and cough. That prompted further investigation, and the chest X-ray showed bilateral infiltrates, and the PCR done showed a positive COVID-19 test. She was directly labeled as a COVID-19 pneumonia and admitted as such. Her worsening and deterioration of her cardiopulmonary status prompted further investigation. A CT was done, confirmed the bilateral infiltrates, but the echo showed a previously undiagnosed severe mitral stenosis with a mild mitral regurgitation. Her mean gradient was 19 millimeters mercury, and a quick picture of a 3D echo is seen here. Severely stenosed, rheumatically changed mitral valve stenosis, and as said, her mean gradient was 19 millimeters mercury. Due to her deteriorating condition, contact was made with us as the primary Center for Excellence for Cardiac Surgery. The first contact was done at 6 a.m. in the morning. A multidisciplinary team meeting was done at 7 a.m. involving interventional cardiologists, cardiac surgeons, neonatal and obstetricians, and the decision was made without any further mitral valve procedure. The life of the baby and her mother and his mother was at risk. So we accepted the patient and admitted her at around 9 a.m. And at 11 a.m. she was in the heart cath, and a balloon mitral valvuloplasty was done with an Inua balloon, single inflation. And due to her very complex mitral stenosis with a very high Wilkins-Epcot score of 11/16, the mitral stenosis went from severe to moderate. However, it resulted in a severe mitral regurgitation. It's better tolerated in pregnant patients, but still the risk was too high to take. An hour later, a second multidisciplinary team meeting was done, and the decision was taken to proceed with a cesarean delivery. A live male baby was delivered and taken to the neonatal ICU, and the patient was taken then to the ICU at 2 p.m. Fortunately, her condition improved significantly over the next few days. She was given methylprednisolone, and with ID follow-up, she was able to be extubated on post-procedural day 3, and at post-procedural day 13, she was even discharged out of the hospital, and the baby then later on discharged on day 30. As we see here, the resulting echo on the right side, first the balloon mitral valvuloplasty up there on the right. As I said, an Inua balloon, a single inflation was done, and the resulting significant MR and the moderate mitral stenosis. The decision was taken to not continue with any further inflations. So the key lessons here, I think the first key lesson is the importance of a multidisciplinary team approach. Whenever we have a complex patient, the best way to go is through multidisciplinary teams. The second thing, we are now in the COVID-19 pandemic era, and this adds another layer of complexity to a well-known disease. And believe it or not, mitral stenosis is still a big thing in developing countries. And even in developed countries, we still see that, especially in young migrants. And the third thing is the potential for other serious conditions accompanying COVID-19. As we saw, the first thing, the first presentation, no further investigations were done, so the COVID-19 was missed. And then when the COVID-19 positive PCR, the patient was just driven into the cliché of a COVID-19 pneumonia, and not even a bedside echo was done, and that's how the mitral stenosis was missed. So I think we should, physicians in general should have a low threshold also to do a bedside echo. That would be my recommendation on that case. Well, the last thing I would say, the happy ending, the thankful mother named her son as Cleveland, just as a thank you for the whole team and saving her life and the family. And he's 8 months now and doing pretty fine. Him and the mother are good. And that's from my side. Thank you so much for having me. Open for questions.
Thanks for a fantastic case. And you know, there's so many layers there, but the multidisciplinary part, first, the cardiac physiology and all that happened and sort of the good outcome is certainly telling, but the multidisciplinary part of this is always when we have cardio OB, and these are really interesting cases, and every case is different. The one thing I wanted to ask you, we still see a lot of mitral stenosis at our center as well. You know, you all knew this going in, high Wilkins score, possibility for a complication of mitral regurgitation. So why, once that was seen, you mentioned that the discussion was to deliver at that point without, I guess, assessing how she was tolerating that. Was she not tolerating that well, or what led to the decision for immediate delivery?
Yeah, that's actually a very good question, because as soon as that happened, her parameters were actually better. And as we know, in pregnancy, the mitral regurgitation is much well tolerated than the mitral stenosis. But seeing that the patient is only 26 weeks pregnant, and she has at least like 6 to 8 weeks to go, that would be like a very difficult situation to leave the patient there. And having that severe mitral regurgitation, it was 3+ to 4. No risk was being taken, and we were reassured from the neonatal team that the best care would be taken of that fetus, and that would be the best option for both mother and fetus at that time.
Great, thank you for that. I again, these are the hardest cases when we're dealing with multiple teams and multiple lives, frankly, and fortunately, it sounds like the decision making turned out very favorable at the end. So sure. We'll have you stop sharing, and I want to end today by thanking all of our discussants today. Again, this is a reminder to us about the importance of advances in science. We've heard a couple of COVID cases, about different types of cases involving imaging and genetic issues, electrophysiology, pediatrics, surgery. So we really do love to see this diversity, but it reminds us that the importance of clinical medicine, good decision-making, multidisciplinary care, and the care team. So thank you for reminding us again about the importance of clinical medicine, and congratulations on your gold medal winners today.